Question 1. A 40-year-old patient presents with a new, rapidly growing lesion on their left forearm. The lesion is irregularly shaped with asymmetry, uneven borders, and multiple colors. The patient has a family history of melanoma. What is the most appropriate next step in the management of this lesion? A. Immediate excisional biopsy of the lesion. B. Monitor the lesion for 6 weeks and schedule a follow-up appointment. C. Perform a punch biopsy to confirm diagnosis. D. Perform dermoscopy to assess for malignant features. Answer: A. Immediate excisional biopsy of the lesion. Explanation: this patient's lesion raises significant concern for melanoma based on its irregular shape, asymmetry, uneven borders, and multiple colors. The family history of melanoma further increases the patient's risk. According to the American Academy of Dermatology's guidelines, melanomas should be excised immediately if they are suspicious, while dermoscopy option D can aid in visualization. The most definitive diagnostic approach is excisional biopsy to remove the entire lesion and obtain tissue for histopathological examination. Monitoring the lesion option B, or performing a punch biopsy option C, would delay diagnosis and could result in insufficient tissue sampling, which is not ideal for melanoma diagnosis. Question 2. A 22-year-old woman presents with severe itching and redness on the flexor surfaces of her elbows and knees. She reports a history of asthma and seasonal allergies. Upon examination, you notice erythematous plaques with a silvery scale. What is the most likely diagnosis? A. Atopic dermatitis. B. Psoriasis. C. Contact dermatitis. D. Lichen planus. Answer: B. Psoriasis. Explanation: the patient's presentation is most consistent with psoriasis, a chronic inflammatory skin disorder characterized by erythematous plaques with silvery scales. Psoriasis typically affects extensor surfaces such as the elbows and knees, and the presence of a family history of atopy, asthma, and allergies is common. The diagnosis is confirmed through clinical evaluation, and histopathology may reveal paracrine, epidermal hyperplasia, and a characteristic pinpoint bleeding, a sign when scales are removed to Auspitz's sign. While atopic dermatitis option A also presents with erythematous patches, it typically occurs in areas such as the face, neck, and flexor surfaces and lacks the distinct silvery scale. Contact dermatitis option C would be associated with a clear exposure history, while lichen planus option D presents with flat top, purple patch, often on the wrists and legs, and does not typically present with silvery scales. Question 3, scenario-based. Mr. Thompson, a 55-year-old man, presents to your clinic with a small, pink, pearly bump on his nose that has been growing slowly over the past few months. He has a history of extensive sun exposure and outdoor work. He is concerned about the lesion as it has started to bleed occasionally. Based on your clinical examination, you suspect basal cell carcinoma (BCC). What is the most appropriate next in managing this lesion? A. Observation and re-evaluation in 6 months. B. Punch biopsy to confirm the diagnosis. C. Perform cryotherapy to treat the lesion. D. Excise the lesion with clear margins and send it for histopathological analysis. Answer: D. Excise the lesion with clear margins and send it for histopathological analysis. Explanation: the patient's lesion, characterized by a pink, pearly bump that bleeds, is highly suggestive of basal cell carcinoma (BCC), which is the most common type of skin cancer. Given his history of extensive sun exposure and the lesion's characteristic, BCC is the most likely diagnosis. The first line of treatment for BCC: surgical excision with clear margins to ensure complete removal and prevent recurrence. A histopathological examination will confirm the diagnosis and guide further management. While punch biopsy, option B, could be used for confirmation, excisional biopsy is the preferred treatment for suspected BCC, as it both diagnoses and treats the lesion in a single step. Cryotherapy, option C, is not appropriate for larger or more. ACS and observation, option A, is not suitable given the suspicion of malignancy. Question 4. A 30-year-old woman presents with a 2-week history of red, raised, and itchy plaques on her forearms and legs. The lesions are well demarcated with a silvery scale. She also reports occasional joint pain. What is the most likely diagnosis? A. Atopic dermatitis. B. Psoriasis. C. Eczema. D. Discoid lupus erythematosus. Answer: B. Psoriasis. Explanation: the clinical presentation of well-demarcated erythematous plaques with silvery scales is characteristic of psoriasis, a chronic inflammatory skin condition. The presence of joint pain raises concern for psoriatic arthritis, which often occurs in patients with psoriasis. Psoriasis commonly affects extensor surfaces such as the elbows and knees. Atopic dermatitis option A is more common in flexure and is often associated with a personal or family history of other allergic conditions like asthma or hay fever. Eczema option C is a general term that can refer to multiple types of dermatitis, including atopic dermatitis, and is not as likely to have the well-demarcated silvery scales seen in psoriasis. Discoid lupus erythematosus option D can present with round erythematous lesions, but they do not typically have the silvery scales seen in psoriasis. Question 5. A 50-year-old male patient presents with an area of hair loss on his scalp, and the affected area has a smooth, shiny appearance. Upon closer inspection, there are no visible scars or inflammation, and he reports that the hair has been thinning gradually. What is the most likely diagnosis? A. Alopecia areata. B. Telogen effluvium. C. Male pattern baldness. D. Tinea capitis. Answer: C. Male pattern baldness. Explanation: the patient's presentation of gradual hair thinning with no scarring or inflammation on the scalp, particularly in male patient, is consistent with male pattern baldness or androgenetic alopecia. This is the most common cause of hair loss in men and is typically characterized by progressive thinning of hair in the temporal and frontal regions. Alopecia areata option A is characterized by sudden, well-defined patches of hair loss, and there may be associated regrowth of white or grey hairs within the bald patches. Telogen effluvium option B is type of diffuse hair shedding caused by various factors, such as stress or illness, and usually involves thinning across the entire scalp rather than focal hair loss. Tinea capitis option D is fungal infection of the scalp that leads to round patches of hair loss, but typically presents with scalp inflammation, scaling, sometimes crusting. Question 6, scenario-based. Mr. Andrews, a 45-year-old man with a history of chronic sun exposure, presents with a suspicious lesion on his lower back. The lesion is asymmetric, has irregular borders, multiple colors, and is approximately 8 millimeters in diameter. He has no pain or itching associated with the lesion. Based on these features, what is the most appropriate next step in management? A. Observe the lesion and perform a follow-up in 3 months. B. Perform a punch biopsy to confirm the diagnosis. C. Excisional biopsy with clear margins. D. Refer the patient to a dermatologist for cryotherapy. Answer: C. Excisional biopsy with clear margins. Explanation: this lesion's features are highly suggestive of melanoma, a malignant skin tumor. The asymmetry, irregular borders, multiple colors, and size greater than 6 millimeters are classic signs described by the ACDE rule for melanoma detection. The most appropriate management for a lesion with these concerning features is excisional biopsy with clear margins. This will allow for both definite diagnosis and removal of the lesion in a single procedure. Punch biopsy, option B, could be used for diagnosis, but excisional biopsy is preferred for suspicious lesions because it provides a full thickness sample and removes the entire lesion. Observation, option A, is not recommended for lesions with suspicious characteristics as it delays diagnosis. Cryotherapy, option D, is not an appropriate treatment for malignant lesions and delay proper diagnosis and treatment. Question 7. A 34-year-old woman with a history of atopic dermatitis presents with pruritic erythematous patches on the flexural surfaces of her elbows, knees, and neck. She reports that the rash has been recurrent and worsens during winter months. What is the most likely diagnosis? A. Psoriasis. B. Atopic dermatitis. C. Contact dermatitis. D. Seborrheic dermatitis. Answer: B. Atopic dermatitis. Explanation: the patient's recurrent pruritic erythematous patches in the flexural areas, elbows, knees, and neck, with history of atopic dermatitis, are highly suggestive of atopic dermatitis, also known as eczema. This condition is often exacerbated by environmental factors such as dry air or cold weather, as reported by the patient. Psoriasis, option A, often affects extensor surfaces and is characterized silvery scales rather than the typical dry, red patches of eczema. Contact dermatitis, option C, typically results from exposure to an irritant or allergen, and the rash would appear at sites of contact with the offending substance. Seborrheic dermatitis, option D, usually presents with greasy yellowish scales in areas such as the scalp, face, and chest, not typically in the flexural areas. Question 8. A 60-year-old man presents with a slow-growing, painless, pearly nodule with visible telangiectasias on his cheek. The lesion has been growing for several months and there is no history of trauma. What is the most likely diagnosis? A. Basal cell carcinoma. B. Squamous cell carcinoma. C. Melanoma. D. Seborrheic keratosis. Answer A. Basal cell carcinoma. Explanation: the lesion described is most consistent with basal cell carcinoma (BCC), which typically presents as a pearly, slow-growing nodule with telangiectasia. BCC is the most common type of skin cancer and often occurs in areas of high sun exposure such as the face. It is generally painless and grows slowly over time. Squamous cell carcinoma (option B) typically presents as this erythematous lesion and may ulcerate, and melanoma (option C) often presents as an irregularly pigmented, asymmetrical lesion, not typically as a smooth, pearly nodule. Seborrheic keratosis (option D) is a benign lesion that appears as a well-demarcated, slightly elevated, wart-like growth and does not usually exhibit the telangiectasias seen in the E. Question 9. A 22-year-old woman presents with a well-defined, round, scaly lesion on her upper back that has been slowly enlarging over the past few weeks. She also reports mild pruritus and occasional stinging. Upon physical examination, the lesion is light-colored with a fine scale. What is the most likely diagnosis? A. Tin corporis, B. Psoriasis, C. Namillar eczema, D. Pityriasis rosea. Answer A. Tinea corporis. Explanation: the patient's well-defined, round, scaly lesion that has been enlarging and causing mild pruritus is most consistent with tin corporis, a superficial fungal infection. Tin corporis often presents as annular lesions with a central clearing and peripheral scaling. Psoriasis, option B, typically presents with silvery scales on erythematous plaques, usually not with the central clearing seen in tinea. Namillar eczema. Option C is characterized by coin-shaped plaques of eczema, often in the winter months, but does not typically present with the characteristic peripheral scale of tinea. Pityriasis rosea, option D, usually presents with a heral patch followed by a more diffuse rash in a Christmas tree pattern, not the single lesion described here. Question 10. A 65-year-old woman presents with a new lesion on her face. The lesion is raised, rough, and has a crusty surface with occasional bleeding. She has a long history of sun exposure and works outdoors. What is the most likely diagnosis? A. Basal cell carcinoma, B. Squamous cell carcinoma, C. Actinic keratosis, D. Sebaceous cyst. Answer B. Squamous cell carcinoma. Explanation: the lesion described is most suggestive of squamous cell carcinoma SE, a type of skin cancer that commonly presents as a rough, raised, and sometimes crusty lesion, often with ulceration or bleeding. SCC typically develops in areas of chronic sun exposure. Actinic keratosis, option C, is a premalignant lesion that can progress to SCC and appears as a rough, scaly patch, but it is not usually as raised or ulcerated. Basal cell carcinoma, option A, typically presents as a pearly translucent nodule with telangiectasias and is less likely to bleed or ulcerate. Sebaceous cyst, option D, is a benign lesion that presents mobile, firm lump beneath the skin but does not have the characteristics of the lesion described here. Question 11. A 28-year-old male presents with a recurrent itchy red rash on his wrists and the backs of his knees. The rash appears as small raised bumps that have become more noticeable in the last few months. He has a history of asthma and hay fever. What is the most likely diagnosis? A. Psoriasis, B. Contact dermatitis, C. Atopic dermatitis, D. Lichen planus. Answer C. Atopic dermatitis. Explanation: the patient's history of asthma and hay fever, along with the recurrent itchy rash on flexural areas such as the wrists and backs of the knees, is most consistent with atopic dermatitis eczema. This chronic condition often occurs in patients with personal or family history of other allergic conditions like asthma or hay fever. Psoriasis, option A, typically affects extensor surfaces and presents with scaly plaques. Contact dermatitis, option B, usually results from direct exposure to an irritant or allergen and typically causes localized skin reactions. Lichen planus, option D, presents as purple flat-topped papules with distinctive lace-like pattern and is not as commonly found in the flexural areas. Question 12. A 50-year-old man presents with a firm, non-tender nodule on his scalp that has been present for several months. The lesion is well circumscribed, has a smooth surface, and has not changed in size. He denies any pain or drainage. What is the most likely diagnosis? A. Basal cell carcinoma, B. Sebaceous cyst, C. Lipoma, D. Squamous cell carcinoma. Answer B. Sebaceous cyst. Explanation: the presentation of a firm, non-tender, well-circumscribed nodule with a smooth surface that has been present for several months is most consistent with A sebaceous cyst, also known as an epidermoid cyst. These cysts are typically slow-growing, benign lesions that contain keratin and are commonly found on the scalp. Basal cell carcinoma, option A, is usually more likely to be an ulcerated or pearly lesion. Telangiectasias, lipomas, option C, are soft, mobile, and typically present as painless, subcutaneous lumps, but they do not usually have a smooth surface like a sebaceous cyst. Squamous cell carcinoma, option D, often presents as a more irregular, ulcerated lesion with associated pain or bleeding. Question 13. A 45-year-old woman presents with a new oval-shaped erythematous rash on her abdomen. The rash has a central clearing and is surrounded by a raised border. She mentions that the lesion has been expanding over the past few days. What is the most likely diagnosis? A. Tinea corporis. B. Psoriasis. C. Pityriasis rosea. D. Lichen planus. Answer: A. Tinea corporis. Explanation: the patient's description of an oval-shaped erythematous rash with central clearing and raised border is highly suggestive of tinea corporis, superficial fungal infection. This type of infection commonly presents as ring-shaped lesion with raised, scaly border and central clearing. Psoriasis, option B, typically presents with well-demarcated plaques that have silvery scale and are not usually ring-shaped. Pityriasis, option C, often begins with herald patch and spreads in a Christmas tree pattern, which is not consistent with the described lesion. Lichen planus, option D, presents with flat, purple, itchy papules and does not have characteristic ringed appearance. Question 14. A 70-year-old woman presents with a small, brownish, asymmetrical lesion on her leg. The lesion is irregular in shape, with uneven borders and several shades of brown and black. It measures about 10 millimeters in diameter. What is the most appropriate next step in management? A. Monitor the lesion for changes over time. B. Perform a punch biopsy of the lesion. C. Apply cryotherapy to remove the lesion. D. Prescribe a topical steroid to reduce inflammation. Answer: B. Perform a punch biopsy of the lesion. Explanation: the lesion described has characteristics highly concerning for melanoma, including asymmetry, irregular borders, multiple colors, and a diameter greater than 6 millimeters. Given the suspicion for melanoma, the next best step is to perform a punch biopsy to obtain a sample for histological examination. Monitoring the lesion, option A, is not appropriate given its features. Cryotherapy, option C, and topical steroids, option D, are not appropriate for suspicious lesions as they may delay diagnosis and treatment. Question 15, scenario-based. A 55-year-old man with a long history of chronic sun exposure presents with a persistent, scaly patch on his ear. The lesion is erythematous and slightly raised with a rough, dry texture. It has been slowly enlarging over the past few months and occasionally bleeds. What is the most likely diagnosis? A. Actinic keratosis. B. Basal cell carcinoma. C. Squamous cell carcinoma. D. Seborrheic dermatitis. Answer: C. Squamous cell carcinoma. Explanation: the patient's history of chronic sun exposure along with the description of persistent, scaly erythematous patch on the ear that occasionally bleeds is most consistent with squamous cell carcinoma. SCC is a common form of skin cancer that often presents as rough, scaly patch or nodule, sometimes with ulceration or bleeding, and is typically associated with sun exposure. Actinic keratosis, option A, precancerous lesion that can progress to SCC, but it is usually not as raised or ulcerated. Basal cell carcinoma, option B, often presents as pearly nodule with telangiectasias, not as rough, scaly patch. Seborrheic dermatitis, option D, is benign, inflammatory skin condition and does not usually have the ulceration or raised, scaly texture of SE. Question 16. A 65-year-old male patient with a long history of smoking presents with a non-healing ulcer on his lower lip. The lesion has an irregular border and a crusted surface. He mentions that the ulcer has been present for several weeks and has not improved despite self-treatment with over-the-counter ointments. What is the most likely diagnosis? A. Squamous cell carcinoma. B. Herpes simplex virus infection. C. Basal cell carcinoma. D. Candidiasis. Answer: A. Squamous cell carcinoma. Explanation: the patient's history of smoking along with non-healing ulcer on the lip is highly suggestive of squamous cell carcinoma. SCC can present as chronic, non-healing ulcer or nodule, often on sun-exposed areas such as the lip. Smoking is a significant risk factor for developing SCC, especially in areas like the lower lip. Herpes simplex virus, option B, typically causes painful vesicles rather than a persistent ulcer. Basal cell carcinoma, option C, is typically nodular lesion that may ulcerate, but it does not present as crusted ulcer. Candidiasis, option D, presents as superficial moist lesion, not chronic crusted ulcer. Question 17. A 40-year-old female presents with a small, sharply demarcated, hyperpigmented lesion on her left forearm. The lesion has a well-defined border and is uniformly dark brown in color. It has been stable for several years. What is the most likely diagnosis? A. Melanoma. B. Seborrheic keratosis. C. Actinic keratosis. D. Lentigo. Answer B. Seborrheic keratosis. Explanation: the description of a well-defined, stable, hyperpigmented lesion with a uniform color is most consistent with seborrheic keratosis. These benign lesions are common in middle-aged to elderly adults and are typically characterized by a well-defined, round or oval shape with a warty or stuck-on appearance. Melanoma, option A, would usually present as an asymmetrical, irregular lesion with an borders in multiple colors, which is not consistent with the described lesion. Actinic keratosis, option C, often presents as a rough, scaly patch, and lentigo, option D, is typically a small, flat, brown spot, often seen in sun-exposed areas, but it usually lacks the raised, wart-like texture of seborrheic keratosis. Question 18. A 22-year-old woman presents with a sudden onset of multiple red itchy bumps on her arms and thighs. The lesions are 1-2 centimeters in diameter and are surrounded by erythema. She has a history of asthma and seasonal allergies. What is the most likely diagnosis? A. Urticaria. B. Atopic dermatitis. C. Contact dermatitis. D. Drug eruption. Answer A. Urticaria. Explanation: the presentation of multiple red, itchy bumps that are surrounded by erythema and have appeared suddenly is most consistent with urticaria hives. Urticaria is a type of allergic reaction that presents as raised, red, and often itchy welts on the skin. The patient's history of asthma and seasonal allergies supports the likelihood of an allergic cause. Atopic dermatitis, option B, typically presents as a chronic itchy rash in flexural areas, not as acute raised bumps. Contact dermatitis, option C, is caused by direct contact with an irritant or allergen and often appears as localized, inflamed skin. A drug eruption, option D, is also a possibility but is less likely without a no new medication or systemic symptoms. Question 19, scenario-based. Mr. Thompson, a 58-year-old male, presents with a new asymptomatic mole on his back. The mole is irregular in shape, has multiple colors, brown, black, and pink, and measures 10 millimeters in diameter. He is concerned about its appearance. What should be the next step in management? A. Perform a punch biopsy of the lesion. B. Reassure the patient and recommend monitoring for any changes. C. Refer the patient for excisional biopsy and removal of the lesion. D. Apply cryotherapy to the lesion. Answer A. Perform a punch biopsy of the lesion. Explanation: the description of the lesion being irregular in shape with multiple colors and a diameter greater than 6 millimeters raises concern for melanoma. The next best step is to perform a punch biopsy to assess the lesion histologically. The punch biopsy will provide a representative sample of the lesion to determine whether it is malignant, reassuring the patient and monitoring the lesion. B is not appropriate given the concerning features of the mole. Excisional biopsy and removal, option C, may be appropriate if melanoma is confirmed but is not the initial step. Cryotherapy, option D, is inappropriate as it may obscure the diagnosis of a potentially malignant lesion. Question 20. A 30-year-old woman presents with an itchy, scaly rash on her scalp and in her eyebrows. She has noticed silvery, flaky patches that bleed when scratched. What is the most likely diagnosis? A. Psoriasis. B. Seborrheic dermatitis. C. Tinea capitis. D. Lichen planus. Answer A. Psoriasis. Explanation: the description of itchy, scaly patches with silvery flakes, particularly on the scalp and eyebrows, is highly suggestive of psoriasis. Psoriasis often presents with well-defined, scaly patches, and the silvery scale is a hallmark of the condition. Seborrheic dermatitis, option B, can also affect the scalp and eyebrows, but it typically presents with greasy scales and redness rather than the silvery scales seen in psoriasis. Tinea capitis, option C, is a fungal infection that often presents with round, patchy hair loss, not silvery scales. Lichen planus, option D, presents as flat, purple, polygonal papules, which is different from the scaling pattern seen in psoriasis. Question 21. A 45-year-old male with a history of chronic alcohol use presents with a sudden onset of painful red and swollen lesions on his lower legs. The lesions have a raised, dusky center with an erythematous border. He also has systemic symptoms including fever and malaise. What is the most likely diagnosis? A. Cellulitis. B. Erythema nodosum. C. Necrotizing fasciitis. D. Deep vein thrombosis. Answer: B. Erythema nodosum. Explanation: the presentation of painful, red, swollen lesions on the lower legs with a raised, dusky center and erythematous border is characteristic of erythema nodosum. Erythema nodosum is an inflammatory condition often associated with systemic symptoms such as fever and malaise. It is commonly seen in conditions like infections, inflammatory diseases, and chronic alcohol use. Cellulitis, option A, with diffuse, warm erythematous and swollen skin, but without the raised, nodular lesions seen in erythema nodosum. Necrotizing fasciitis, option C, would present with rapidly progressing tissue necrosis, pain out of proportion to physical findings, and systemic toxicity. Deep vein thrombosis, option D, usually presents with pain, swelling, and redness of the lower leg, but not with raised nodular lesions. Question 22. A 34-year-old woman presents with a recurring painful red and swollen rash on her face, particularly around the eyes and nose. She has a history of rosacea, and the lesions seem to worsen after sun exposure. What is the most appropriate treatment for her condition? A. Topical corticosteroids. B. Oral antibiotics, tetracyclines. C. Antifungal creams. D. Oral acyclovir. Answer: B. Oral antibiotics, tetracyclines. Explanation: this patient's presentation of recurring, painful red and swollen lesions on the face, particularly around the eyes and nose, along with a history of rosacea, suggests that her rosacea is exacerbated. The most effective treatment for rosacea involves oral antibiotics such as tetracyclines, e.g., doxycycline, which have anti-inflammatory effects. Topical corticosteroids. Option A can worsen rosacea in the long term and are generally not recommended. Antifungal creams, option C, would be used for fungal infections but are not effective for rosacea. Oral acyclovir, option D, is used for viral infections, particularly herpes simplex, but is not indicated for rosacea. Question 23, scenario-based MS. Anderson, a 28-year-old woman, presents with new-onset hair thinning and the presence of round, smooth patches of alopecia on her scalp. She is otherwise healthy and has no family history of hair loss. On examination, there is no scarring or redness, but the patches are completely devoid of hair. What is the most likely diagnosis, and what is the next step in management? A. Telogen effluvium. Perform a scalp biopsy. B. Androgenetic alopecia. Start minoxidil. C. Alopecia areata. Initiate treatment with intralesional corticosteroids. D. Tinea capitis. Prescribe oral antifungals. Answer: C. Alopecia areata. Initiate treatment with intralesional corticosteroids. Explanation: the description of round, smooth patches of hair loss with no scarring is highly suggestive of alopecia areata, an autoimmune condition that causes non-scarring hair loss. The next step in management is to initiate treatment with intralesional corticosteroids, which are effective in promoting hair regrowth in affected areas. Telogen effluvium option typically presents as diffuse hair shedding, not discrete patches, and is not typically treated with a scalp biopsy. Androgenetic alopecia, option B, typically results in a gradual diffuse thinning of hair, usually in a pattern distribution. Tinea capitis, option D, causes patchy hair loss with broken hairs and is treated with oral antifungal therapy, but there is no indication of fungal infection in this case. Question 24. A 50-year-old male presents with a suspicious lesion on his nose that has an irregular border, variegated color, and has been growing steadily for the past 6 months. The patient is concerned about skin cancer. What is the best next step in management? A. Perform a punch biopsy of the lesion. B. Perform a shave biopsy of the lesion. C. Excise the lesion with wide margins. D. Schedule a follow-up in 6 months to reassess the lesion. Answer: A. Perform a punch biopsy of the lesion. Explanation: the description of an irregular border, variegated color, and steady growth is highly concerning for melanoma. The next best step is to perform a punch biopsy, which allows for the removal of a full-thickness skin sample to assess the lesion histologically for malignancy. A shave biopsy, option B, may not be ideal as it might miss the full depth of the lesion and could interfere with histological evaluation. Excision with wide margins, option C, is appropriate once melanoma is confirmed, but it is not the initial step. Scheduling a follow-up, option D, would be inappropriate given the concerning features of the lesion, and a timely biopsy is necessary for diagnosis. Question 25. A 12-year-old boy presents with multiple small raised flesh-colored papules on his face and neck. He is otherwise healthy, and his parents report that the lesions have been present for several months. What is the most likely diagnosis? A. Molluscum contagiosum. B. Acne vulgaris. C. Warts. D. Seborrheic keratosis. Answer: A. Molluscum contagiosum. Explanation: the presentation of multiple small raised flesh-colored papules on the face and neck in a healthy child is most consistent with Molluscum contagiosum, a viral infection caused by a poxvirus. These papules are often dome-shaped with a central umbilication. Acne vulgaris, option B, typically presents with comedones, pustules, and nodules, not raised papules. Warts, option C, would typically present as rough, raised lesions, often with a rough surface, and are caused by the human papillomavirus. Seborrheic keratosis, option D, is more common in adults and presents as raised, often pigmented lesions with a stuck-on appearance, not flesh-colored papules. Question 26. A 60-year-old woman presents with an asymptomatic, irregularly shaped, brownish patch on her back. The lesion has increased in size over the past year and has an uneven color with areas of dark brown and black. On physical examination, the lesion is raised and has a jagged border. What is the most likely diagnosis, and what is the next step in management? A. Basal cell carcinoma. Perform an excisional biopsy. B. Squamous cell carcinoma. Perform a punch biopsy. C. Melanoma. Perform an excisional biopsy with wide margins. D. Seborrheic keratosis. Monitor the lesion for changes. Answer: C. Melanoma. Perform an excisional biopsy with wide margins. Explanation: the lesion's irregular shape, uneven color, and rapid growth are concerning for melanoma, a highly malignant form of skin cancer. The next step is to perform an excisional biopsy, as this allows for complete removal of the lesion with adequate margins and provides tissue for histological examination. Squamous cell carcinoma, option B, would typically present as firm, red, scaly nodule or ulcer, and basal cell carcinoma, option A, usually presents as a pearly translucent nodule with a central ulceration. Seborrheic keratosis, option D, is a benign lesion often presenting as a well-demarcated, raised, and a stuck-on appearance, but it is not typically asymmetrical or growing rapidly like this lesion. Question 27. A 42-year-old woman presents with a widespread, scaly rash on her arms, legs, and scalp. The lesions are well-defined erythematous plaques with silvery scales. She has a family history of psoriasis, and the lesions are not pruritic. What is the most likely diagnosis? A. Atopic dermatitis. B. Lichen planus. C. Psoriasis. D. Eczema. Answer: C. Psoriasis. Explanation: the patient's presentation of well-defined erythematous plaques with silvery scales, especially on the arms, legs, and scalp, is characteristic of psoriasis. Psoriasis is a chronic inflammatory skin disease with a strong genetic component. It is characterized by accelerated epidermal turnover leading to the formation of scaly plaques. Atopic dermatitis, option A, typically presents as pruritic eczematosly, often in the flexural areas, and is more common in children. Lichen planus, option B, presents with purple flat-topped polygonal papules often involving mucous membranes and is typically pruritic. Eczema, option D, refers to a group of inflammatory skin conditions which may present similarly to psoriasis but typically lacks the characteristic silvery scales and has a more diffuse distribution. Question 28, scenario-based. Mr. Williams, a 32-year-old man, presents with a 3-week history of painful red and swollen vesicular lesions around his left eye. He reports the burning sensation and mild fever. The lesions are crusted, and he has a history of cold sores. What is the most likely diagnosis, and what is the next step in management? A. Herpes simplex virus HSV infection. Initiate oral acyclovir. B. Varicella zoster virus VEV infection. Initiate oral acyclovir. C. Cellulitis. Prescribe oral antibiotics. D. Impetigo. Prescribe topical mupirocin. Correct answer: A. Herpes simplex virus HSV infection. Initiate oral acyclovir. Explanation: the patient's history of cold sores, painful vesicular lesions around the eye, and burning sensation is consistent with a herpes simplex virus HSV infection. The presence of crusted lesions and systemic symptoms such as fever supports the diagnosis. The most appropriate treatment for HSV is oral acyclovir, which helps viral replication and severity of symptoms. Varicella zoster virus VEV infection, option B, also causes vesicular lesions, but VEV typically presents as a unilateral dermatome-specific rash and is associated with a history of chickenpox or shingles. Cellulitis, option C, would present as A diffuse erythematous, warm and tender skin infection but without the vesicular lesions in Ichis impetigo option would present with honey-colored crusts, often in younger children, but the lesions are not vesicular and systemic symptoms are less common. Question 29. A 25-year-old woman presents with a localized raised erythematous rash on her lower back that has been present for 2 weeks. The patient also reports mild joint pain but denies fever or systemic symptoms. Physical examination reveals a well-demarcated erythematous plaque with a silvery scale. What is the most likely diagnosis? A. Erythema multiforme. B. Psoriasis. C. Seborrheic dermatitis. D. Tinea corporis. Answer: B. Psoriasis. Explanation: the presence of a well-demarcated erythematous plaque with a silvery scale is classic for psoriasis. This patient's mild joint pain also raises suspicion for psoriatic arthritis, which can be associated with psoriasis. The rash on her lower back is consistent with the common distribution of psoriasis plaques. Erythema multiforme, option A, typically presents with target-shaped lesions and is often triggered by infections or medications. Seborrheic dermatitis, option C, typically involves areas rich in sebaceous glands, such as the scalp, face, and upper chest, and presents with greasy yellowish scales. Tinea corporis, option D, is a fungal infection that presents with annular, scaly lesions with raised borders, but it lacks the silvery scale characteristic of psoriasis. Question 30. A 55-year-old man presents with a non-healing ulcerated lesion on his upper lip. The lesion has a raised border and appears pearly with visible telangiectasia. The patient has a history of significant sun exposure. What is the most likely diagnosis and what is the next step in management? A. Basal cell carcinoma, perform an excisional biopsy. B. Squamous cell carcinoma, perform a punch biopsy. C. Melanoma, perform an excisional biopsy with wide margins. D. Actinic keratosis, monitor the lesion for changes. Answer A. Basal cell carcinoma, perform an excisional biopsy. Explanation: the lesion's appearance is a non-healing ulcerated lesion with a raised border, pearly appearance, and visible telangiectasia is characteristic of basal cell carcinoma BCC, the most common type of skin cancer. The next step in management is to perform an excisional biopsy to obtain tissue for histological examination. BCC typically occurs in sun-exposed areas and is locally invasive but rarely metastasizes. Squamous cell carcinoma, option B, would present as a firm, scaly lesion that may be ulcerated, but it tends to have a more well-defined keratotic surface. Melanoma, option C, typically presents as an asymmetrical, irregularly pigmented lesion, often with rapid growth. Actinic keratosis, option D, is a precursor lesion to squamous cell carcinoma, presenting as a scaly patch, but it does not have the characteristic raised pearly appearance of E.